Good evening, everyone. I hope everyone is having a great day on this Cinco de Mayo. If you celebrate it, I would like to welcome you to our first event of the Concord Alumni Chapter of Delta Sigma Theta Sorority Incorporated, May Week 2025, Reaching, Teaching to Empower Our Communities. I am Darnisha Edenfield, and I will be your moderator this evening as we go through the Middle-Aged Woman's Chronicles, talking about perimenopause and menopause. Please welcome our president of the Concord Alumni Chapter of Delta Sigma Theta Sorority Incorporated, Sor Bridget Herring Williams, as she provides us with a welcome.
Great evening, everyone. And thank you, Sora Darnisha, for sounding so excited having me here this evening. But welcome to all of my beautiful sisters out there in this virtual space. We are so glad that you are here with us this evening. Tonight's webinar is all about you, all about us, all about our journey, our bodies, and our well-being through this perimenopause and menopause. Tonight, we'll explore how to move through it with grace, strength, and confidence while creating a space of knowledge, empowerment, and sisterhood. Thank you so very much to our May Week committee for bringing this webinar to us this evening. Thank you to Sora Darnisha Eddingfield for moderating this evening. And thank you so very much to our soror, Dr. Mila Freeman Kwaku. Did I get that right? I
You
hope I
did,
did.
Mala Freeman
Thank
Kwaku.
you for being here with us this evening. And again, thank you all so much for your presence with us. And Sora Darnisha, I am going to turn it back over to you so that we can get started.
All right. Thank you, Sora Bridget Herring Williams. Ladies, let's talk. We're talking about this with our mothers, our aunties, our cousins, or our sister friends. We are comparing notes as we try and encourage each other during this time. I remember growing up and as a teenager, as a little girl, my mother and grandmother was saying, I'm going through the change. I'm going through the change of life. I don't know about you all, but I know there's a lot of you out there that heard those same words. So, without further ado, we are grateful and we are honored to have one of the best OBGYNs in the Charlotte area to talk about this with us this evening. I would like to introduce to you my esteemed SOR, Dr. Mala Freeman Kwaku, MD, a physician sought after speaker, consultant, medical educator, and expert witness. With over 22 years of experience as a certified OBGYN, Dr. Freeman Kwaku currently practices at Arboretum Obstetrics and Gynecology, modeling superior patient care through intentional, holistic, and collaborative approaches, resulting in enhanced treatment outcomes. A Sikh trained expert, witness, and internationally sought after speaker, Dr. Freeman Kwaku is known for her unique insights and expertise. She brings valuable perspectives to discussions on women's health, medical education, and healthcare operations. Topics such as women's empowerment, mental health and self-care, maternal wellness, motherhood and life balance, and global perspectives in healthcare, just to name a few. Dr. Freeman Kwaku earned her MD from the University of Virginia, where she was also initiated into Delta Sigma Theta Sorority Incorporated's Kappa Rho chapter in the spring of 1990 and completed her residency in obstetrics and gynecology at Georgetown University Medical Center. She is a fellow of the American College of Obstetricians and Gynecologists and an active member of several professional organizations, including the North American Menopause Society and the Ghana Physicians and Surgeons Foundation. Dr. Freeman Kwaku enjoys spending time with her spouse, four children, her faith community, and travel globally. Ladies, let's give a virtual hand, to Dr. Freeman Kwaku.
I'm giving you all a virtual hand too. Can you hear me?
Yes.
I'm so excited to be here. I don't know. There's something about the crimson and cream and just being in the presence of so many swords. It just makes me feel so excited. Thank you for that wonderful welcome. Thank you for asking me to come and speak tonight. This is a very hot button topic. And Sora Portia, who knows me very well, will tell you that I love speaking on women's health issues, and I'm just a sort of a Susie Chatty, if you know me. So I'm hoping that this will be an interactive meeting tonight, that any questions that you all have that I may be able to answer, that I can answer them. And, you know, I hope that you'll come from this with more education about perimenopause and menopausal symptoms. I want to give a couple of disclaimers before I start. Obviously, every woman is different. Every woman's health journey is different. Every woman's health history is different. And so something that I may say for one person may not be applicable to all. The second thing is I realized that there's this whole movement lately of women trying to get more knowledge about menopause, perimenopause. And I will say, at the defense of most of us OBGYNs, that there are a lot of OBGYNs that trained, you know, either when I trained 23 years ago, that may have not had a lot of information about menopause because, you know, in the past it was a male dominated specialty. And, you know, being that it was a male dominated specialty, a lot of the initial people who were trained were men, who did not understand menopause and probably didn't do a lot of research, or there wasn't a lot of research in it. But I think as the years have progressed and more women have become involved in OBGYN, we have come to know that there is a wealth of knowledge that we know. There's a wealth of knowledge that we've yet to come to know. And so some of this, we're all kind of coming up to speed at the same time. So there's also this information that women get from their moms and their grandmoms, and some of it may be very superficial and some of it may be inaccurate. And so we want to hope that some of this information sheds light on some of the facts about perimenopause and what we do know. And then the fourth thing I want to say is that there's a lot of lack of understanding. I feel like in my training, I had a lot of training on menopause treatment and how to treat women that are in menopause. But I think, you know, just like until I was pregnant and understood, you know, what round ligament pain was like and different things that happened when I was pregnant, I really did not have a firsthand and in-depth understanding of menopause until I myself went through menopause several years ago. And so, you know, a lot of this is a learn as you go sort of thing. So I have a PowerPoint presentation tonight to just kind of give some, you know, basic facts or some things that most people have either asked me or they want to know, just to be able to have some sort of discussion about perimenopause. So the first slide is one of my favorite places, which is the beach. I love the beach, so that's why I picked that slide. And I picked the title of Perimenopause, It's a Journey, Not a Place. Because so often women are using the term, am I in perimenopause? Have I got to perimenopause yet? Am I in perimenopause? And perimenopause is a continuum of time. And it's the time that women go through various changes in their bodies, in their physiology, psychology, right before the periods just completely stop. And that time difference, that phase is different for every woman. And that journey is different. The symptoms can be different. The time that lasts before your periods actually stop can be different for everyone. But in general, perimenopause is basically that time before your periods completely stop. And for most women, you can start having some what I call soft symptoms, you know, in your late 30s, maybe early 40s, but certainly by your late 40s, a lot of women are having some of those symptoms. So in this, the last slide that was up with introduction, we were talking about when does it start. We're going to talk about changes that you can expect either physically, emotionally, hormonally, how to manage and cope with those changes, and how to speak to your provider about treatment or help and the kinds of things that we try to recommend our patients have. So when we talk about the symptoms of perimenopause, we talk about a lot of times there's physical symptoms, okay? There's some physical symptoms and there's some other symptoms that we'll talk about. But the first one that most people notice is your periods start becoming irregular. And the easy way that I describe this is if your periods come every month, say every 28, 26 to 35 days regularly, they may start coming every 2 weeks. They might start coming every 3 months. They start doing funny things that are very annoying to us because we like to know when our periods are coming. We like to have our pads and our tampons all ready. And we like to know what's going to happen. And sometimes when you get in those years in your mid to late 40s, your period just starts doing whatever it wants to do. It can start becoming lighter, or for a lot of women, it can start coming more frequent and it can start becoming more heavy. And that is especially irritating. In addition to that, you may have cycles that come regularly, but now you're starting to have hot flashes. And if you don't recognize what a hot flash is, if you're lucky enough to have seat warmers in your car, I would say for me, that's what it feels like, is all of a sudden, I'm wondering, is my seat warmer on? Because my back starts getting hot, or maybe your face starts getting hot, or your body just feels like it's roasting under like a Kentucky Fried Chicken light. And then all of a sudden, you know, it goes away. Well, here's a new fact that I didn't know. You can start having cold flashes. All of a sudden, you're sitting there and you're feeling like someone has put an ice cube down your back and you're freezing. And I'm blessed to have hot flashes and cold flashes. So it's completely ridiculous when I go to bed at night because I'm sleeping with a heating blanket until the middle of the night when I start getting hot, and then I throw that off because I'm now hot. It's crazy. Because you're having hot flashes, you can have night sweats, or you're waking up in the middle of the night, your gown is soaked, your bed is soaked. And because of that, you're not sleeping well. You may all of a sudden start having changes in your libido where you don't feel like having sexual activity. You're not thinking about sexual activity. And one thing that I didn't realize you get a lot of is joint pain. You know, you might have pain in your back, pain in your knees. All of a sudden going up the stairs seems difficult. Maybe you're waking up in the morning and you're starting to hear things crack that you didn't hear crack before. And all of those are due to the fluctuations in your hormones that cause these very uncomfortable and unpleasant symptoms. Emotional symptoms, mood swings, you're irritable, you're anxious, and you're depressed, especially the last two, anxiety, yes, the joint pain, especially the anxiety and the depression. Lack of estrogen or fluctuations in your estrogen can very much cause people who have underlying anxiety or depression to get worse. Some women feel like their heart is racing. I had a patient today tell me that she feels like her heart is palpating. that she feels like she wants to run. And it can be very, very frightening when all of a sudden you're having these symptoms that you've never had before and you have no idea where they're coming from. Because of the lack of sleep and lack of, very deep sleep, you may start having issues with irritability, feeling grumpy during the day. You can't remember things. You don't know why you went up the steps for something, and then you're going back down the steps, and then you remember you went up to get a pencil, and then you go up to get the pencil, and you don't remember what you got a pencil for, and difficulty concentrating. So all of these are the emotional symptoms of perimenopause leading into the menopausal state. Now, the next slide is very important because a lot of women come in and the first thing they say, can you check my hormones? Can you check my hormones? I want to tell y'all that in general, checking hormones is not a thing. Because if you look at the first slide there, that is the hormonal fluctuations that are due to, if you see here, I don't know if you can see my pointer. This is the normal menstrual cycle of someone who is not in menopause or perimenopause. If you look, you go from day 0 to day 14 on average, you will ovulate. And day 14 to 28, you're waiting for your cycle. And then after day 28, you have your period. And during that time, if you look, as you're going to ovulate, your estrogen rises very high, and then it goes down, and then it kind of tapers off. Your progesterone after ovulation, which is the hormone that your ovary makes when you do produce an egg, it goes up after you ovulate. And that's what gives us the gassiness, constipation, sometimes diarrhea, feeling belchy, feeling full, causes us to retain water. So all of those things are very predictable. And if we look at certain hormones like LH and FSH, those are two hormones that our brain emits to talk to our ovaries. So in general, when you're having regular menstrual cycles, I usually tell women that your brain hormones, your LH and your FSH, should generally be pretty low unless you're right at ovulation where you see the LH has a little surge. But when you're getting menopause, if you look below, the FSH and LH are very high. So the analogy that I like to use is that when your ovaries are working fine, your brain doesn't have to talk too loud to it. It's kind of whispering, go on and make some estrogen because you still working. But at the bottom, when your ovaries are quiet and they're not making a lot of estrogen, your FSH and your LH are shouting. So sometimes we'll test those hormones when women say they've been maybe wearing an IUD and they're 53 and they're not sure if they're having menopause or not. Sometimes we'll test them for that reason. But if you look at the graph on the bottom, when women are in menopause or even perimenopause, that estrogen and progesterone is just doing all kind of wild things. And it doesn't tell you anything because your estrogen can be very high, but because it's fluctuating, if you tested it at the wrong time, it can be low, it can be high, it can be low, it can be high. And so that those kinds of hormones really don't tell us a lot about where you are in your menopause journey. So a lot of times when women ask, can I have my hormones tested? I mean, in my head, my face is smiling, but my eyes are rolling back in my head because it's really a waste of money because it really doesn't tell us a lot. We really like to listen to what symptoms you're having, because if you're having cycles every 3 months and you're having hot flashes, I can tell you that you're in perimenopause without even testing any blood work. And it's because of those cycles, those crazy erratic cycles of your estrogen, that is what is causing those hot flashes, because your brain has an area in it that has a receptor for that estrogen. And when it's high and it's low, when it's high and it's low, your brain is just firing off all kinds of signals and it's engendering these kinds of uncomfortable hot flashes. If you also look at the bottom, your testosterone levels decline. And once you're in menopause, you may have very little, or even your testosterone could technically be 0. And testosterone is that hormone that helps us with our libido and makes us feel like we want to have sexual activity a lot of times, in addition to our estrogen, but testosterone especially. So it's really important during those times to know that some of those erratic changes are due to the fact that your hormones are doing what's natural, but it doesn't mean we have to leave them alone and just let them do that, because a lot of times the loss of these hormones is producing very unpleasant symptoms. When we look at different health risks and concerns, we talk about osteoporosis, and osteoporosis is basically where your bones stop building and they start becoming more brittle. It's less likely in, women that have very heavy bones, and generally African American women have pretty good bone density. But we can also have osteoporosis due to decreased estrogen levels. And it can increase the risk that you're going to have osteoporosis, especially if you have a family history, if you're not doing weight-bearing exercise, if you're also low in certain supplements such as calcium and vitamin D that tend to work together. And especially looking at cardiovascular health, we look at changes in the lipid profile. Someone who has very normal cholesterol when they're menstruating regularly, in menopause, they may notice that their cholesterol is now increasing to the point that they may now need to take medication for it. And that's why heart disease is the #1 killer of women, especially as we enter menopause, because of the lack of estrogen, and also because of some of the lifestyle choices that we have as we get older, such as gaining weight, obesity, diabetes, and high blood pressure. So those are things that are very important for us to really acknowledge and take careful consideration to manage to avoid having problems with our heart disease, having heart disease. We also talked about mental health and the impact on mood disorders. So for instance, something that like anxiety or depression that's been well managed with, maybe exercise or a low dose medication for anxiety. As you get older, you may need to increase your medication, or you may need to try some other types of interventions, because you may feel like your anxiety is increasing, you're feeling more depressed, and that's a natural result of having less estrogen. Those are not imaginary things. So management and coping strategies on the next slide. We're talking about lifestyle modifications and hormone therapy, or basically the two different ones. Now, I really can't stress this enough. And I think that a lot of times women feel like we're picking on them because we're talking about, oh, we need to lose some weight, or you've got to adopt a heart healthy diet. And, it's very difficult to control your weight as you get older, because your lifestyle has not been modified. Maybe, we can't eat like we can when we're 50, like we did when we're 20. We can't have the same level of activity when we're 50 like we did when we're 20, because maybe when we're 20, we're exercising and doing, very active things. And as we get older, we become more sedentary, more comfortable. Our food choices change. But honestly, I can't stress this enough. There's no way you're going to get through menopause unless you start changing some of your lifestyle choices. And, healthy diet, regular exercise, especially, weight-bearing exercise. Weight-bearing exercise or lifting weights helps you build muscle, which supports your structure of your body, your bones and ligaments, which helps with some of the joint pain. And also, as you build muscle, your body becomes leaner, and it helps you burn the fat that you do have better. So sometimes you may not notice that your weight is changing a lot, but you may notice that your size is becoming smaller. And that's one benefit of adopting weight training in your perimenopausal/postmenopausal journey. And I really do encourage that a lot in my patients that are in their 30s, as I warn them that as they get in their 40s, they're going to notice that their weight is going to start to climb if they don't change some of their habits. We also want to make sure that you're adopting stress management techniques. So, my go-to used to be hot wings and fries. It cannot be that anymore. I have to get on the treadmill, run. There's prayer, there's yoga, there's walking outside to music, a lot of different things to help manage stress, because your mind changes, your body changes, and a lot of times your life changes. You have more stress as you get older. Children are growing, marriages are changing, different things are happening. And we have to find a better way to manage that, because in addition to having all these external things, we have all of these things going on within our bodies that are making, things a little bit different and more challenging than they were before. And sufficient sleep hygiene. I am guilty of it. This is my favorite place. I'm sitting in my playroom in front of this TV over there, and the computer's in front of me, and I will sit here and surf Facebook at night while I'm watching the television. Very bad habits. That blue screen interaction with our phones. A lot of times we have to adopt healthy habits as we're going to sleep, because your sleeping habits will change. You'll become more likely to wake up in the middle of the night. And so I always encourage, and I try to adopt myself. It's very difficult to do so, but I try to follow my own advice, which is, turning off the stimulation in, a reasonable time, 8 or 9 o'clock, maybe picking up a book, doing some stretching, having some chamomile tea, not letting, watching news and things that are exciting to you right before you sleep. And then trying to get into bed at a reasonable hour, because a lot of times you will wake up in the middle of the night, maybe because you're having a hot flash. And sometimes I'm not sure if we even know why people do that, but I've had a lot of patients complain they'll wake up at 3 o'clock in the morning. And I also had a period that I did that. I'd wake up at 3 o'clock in the morning, my eyes would pop wide open. And the only thing I could do is just either, sometimes I could roll over and go back to sleep. And sometimes I encourage people, get up and fold some laundry, or, organize the cans in your cabinet until you're bored for an hour, and then try to get back in bed and get another couple hours of sleep. But it's really important to have good habits to help you sleep better at night, because sometimes sleep can be challenging. If all of those things fail, and we're talking about treatment, there's hormone replacement therapy, but that also has benefits, and that also has some risks. It's not, going to be great for everyone, but the majority of women can safely take, what I call FDA approved hormone replacement therapy without any problems, as long as there's a risk benefit discussion with your physician. We also talk about holistic treatments. Caffeine, sugar, and alcohol will make your hot flashes worse. So some people respond differently to different things. I mean, I used to have a big piece of cake or something that before I go to sleep, and I would wake up just in a cold sweat. And so I've reduced my intake of sugar, especially at night. It's helped me lose some pounds, which is great. And then alcohol, like red wine that has sulfates in it and things like that, can also increase your increase your hot flashes at night. And so you don't have to give it up. You just have to know what are your triggers. And for me, I love, love, love cheesecake. And the good thing about cheesecake is it has about 40 grams of carbohydrates in. No, actually, it may not even have that much. It's lower in carbohydrate than a lot of desserts. And if I make it myself, I usually make it with half as much sugar, because I like the texture. But most times if I get a piece of cheesecake from the store or a restaurant, it may take me a week to eat it, because I will eat like two bites every night, just so that I can have the taste of the cheesecake, but not all the sugar that's going to end up making me have hot flashes at night. So you want to try to avoid as much like caffeine, sugar, alcohol, or at least in moderation, because they may trigger you. And then exercise, of course, is also very helpful to help your body adjust to this very challenging time in life. So when we look at hormone therapy, as far as, what to treat, how to treat, there's many different ways of doing this. And that's why it's important, I feel, to really look at every patient differently and to individualize, because not one thing is going to be great for every woman. If you're early in perimenopause, like you're 42, 43, and your periods are becoming irregular, you're having hot flashes, a lot of times a low dose birth control pill or some other kind of hormone that has estrogen and progesterone in it, like the ring, the patch, or birth control pills, are great because they will help regulate your period. They usually make your period lighter. The estrogen in it usually prevents you from having a lot of those hot flashes. And so when you're early 40s, mid 40s, and you're having those kinds of symptoms, most of those are going to be pretty safe for most women. If they desire that, they can take that until they get near menopause, and then we can make some other changes. Late perimenopause, say 46, 47, when maybe there's more symptoms, hot flashes, the periods are maybe becoming heavy. I always try to do some sort of workup to see, like, why are they heavy? A lot of women have fibroids and other things that we can treat. But one thing that I particularly like using a lot is intrauterine devices, such as progesterone secreting IUDs. Liletta, Mirena are usually best. They contain enough progesterone in them that when they're placed in the uterus in the office, they can reduce the intensity of your menstrual cycle, so that your period is still there, but it's lighter. And so if I have a patient that's wearing an IUD and she's 50 and she says, I'm not having periods, but I'm having hot flashes and I'm not quite sure if they're in menopause, because they have the progesterone right in the uterus, um, because they have the progesterone right in the uterus, if you need to add something extra, such as a low dose estrogen patch, you can safely do that in a late perimenopausal woman. And then as she moves into menopause, because the progesterone and the IUD is there, you can transition her to a full dose estrogen patch to help manage her symptoms. So I particularly think it's a very low maintenance way of managing menopause. And the patch of estrogen is the safest way to give estrogen through the skin, as opposed to taking a pill. Even though the pill is safe, when you compare the two, the patch is supposed to be safer from a standpoint of risk of blood clots and those sorts of things. And that's why a lot of OBGYNs are using IUDs. Sort of, it's an off-label use, but I have a feeling that very soon it's going to become one of the FDA recommended forms of progesterone that women are going to be able to use. And then there's the role of pellet therapy. Pellet therapy is another way of delivering estrogen, progesterone, and testosterone by placing small granules of the hormonal pellets under the skin. The North American Menopause Society, which is probably the organization that looks at most of the treatments and research in menopause symptoms, does not look very favorably on pellet therapy. It is not FDA approved. And the problem with pellet therapy is when we give you estrogen by mouth or we give you estrogen in a patch, we are using the lowest dose we can to try to decrease the symptoms that you're having. So we don't give you a patch and then measure how much estrogen you're getting. We give you a patch and say, how are you feeling? How many hot flashes are you having? And I usually tell women, if I put you on a medium strength patch and you're having 1 to 2 hot flashes a day, that's probably about right for you. I wouldn't want to give you more hormone than you needed, because hormones can have risks. And so the problem with pellet therapy is every woman's absorption rate of the hormone is different. They're given in different doses, but it's impossible to remove the pellet. And so once you have the pellet placed, if you're getting way too much estrogen or way too much testosterone, you basically just have to wait until the pellet wears off. And so that is where the problem lies with pellets. And personally, what I've seen is a lot of times you have people using pellets or people dispensing pellets who may not have the kind of knowledge to manage some of the side effects that the pellets cause. And a lot of times what happens is I'll get patients referred to me who are using pellets and they're having heavy bleeding and they're menopausal, which is not normal. And what we have to do is diagnostic testing and see why are they having this amount of bleeding. And usually by the time they're referred to me, the person has given them more progesterone, less, more estrogen, and they're sort of treating the irregularity by giving them more hormones, which is only making it worse. And so the problem with that is, when you have too much estrogen, that can cause abnormal cells to grow within the uterus. And that can lead to atypical cells, anything from atypical cells to full-fledged cancer of the uterus. And so you definitely want someone who has the knowledge to understand how these things work and also to be able to treat the side effects that come from them to use this. This is not something that I would go to your local med spa to get. And that's just it's not only my personal opinion, but it's the North American Menopause Society's opinion about this. And as you see, there's more and more commercialization of this as people get more information about the discomforts of menopause. But there are FDA approved ways of treating this that are covered by your insurance through your gynecologist, and you do not have to pay hundreds of dollars for lab testing and hundreds of dollars for the hormones. Yeah. And then someone is mentioning over-the-counter supplements, and that's another thing. Soy based products, isoflavins. There's several different nutritional supplements that are available, and they there's been research done on them, and the amount that they are able to help has been anecdotal, but it doesn't mean that they don't help at all. It just means that they're not really found to be that helpful. But I have patients who take different things and they find it helpful, and other people who don't. And so, you know, they don't hurt, that's for sure, because most of them are sort of vitamins and supplements. But I also find that if I have patients acknowledge that, losing weight, eating a diet low in sugar, or trying to reduce sugar in their diet, alcohol, caffeine, they do find that, sometimes even that alone is enough to make their hot flashes and some of their symptoms better. So the last slide is the recap of the points that we talked about, where we talked about, what is perimenopause? When do women go, when are women in the perimenopausal age range? We talked about some of the symptoms of hot flashes and perimenopause. I'm sorry, symptoms of perimenopause and why that's happening because of the wild fluctuations in the hormones, and, what different health risks that come from loss of estrogen and how we can manage those risks by either the addition of lifestyle changes or the replacement of hormones through FDA approved medications for the symptoms of menopause. So the last slide is me in the office. My office is, we used to be Arboretum Obstetrics and Gynecology. I had a few partners and we lovingly delivered babies for 20 years. And now we just focus on gynecology. And there's our website, and we're also on Instagram and Facebook if you'd like to follow us. I usually post a couple times a week different, videos on health related tips for women. So I'd love to have you follow us. So I'd love to entertain any questions if you have any.
And I just want to thank you again, Dr. Freeman Kwaku, for joining us. And I wanted to read some of the comments before we go into the questions. And I mean, everyone seems to have the same type of feeling about perimenopause and menopause, talking about, yep, just does what it wants to do with the fan on, the joint pain. And these are things I see my mom going through. Lord, just breaking out into a sweat. I feel so bad for her. My shoulder is giving me problems. My emotions are all up over the place. The joint pain is real. And another one said their mother has a lot of the mentioned symptoms. And another one says they wake up every morning at 3 a.m. And another one agreed, yeah, me too, yes. And I'm waking up in the middle of the night. I have to drink ice espresso in the morning in order to function at work because I'm so tired and just wow. And you answered the question about over the counter supplements. And there's a question here. What if the Mirena is not working? What do you need to ask the provider?
One thing that I love to specialize in my office is bleeding, heavy menstrual bleeding, fibroids, and especially like postmenopausal or perimenopausal bleeding. I'll just share like a story or a personal story. I had an aunt who probably, I think 8 years ago, she had sort of a polycystic ovary kind of bleeding, where that's where you kind of don't ovulate, but you just kind of bleed anytime you want to. And that kind of bleeding can lead to growth of abnormal cells because your body needs to either shed in a regular fashion, or you need to have something like a pill that's keeping the lining from building, or an IUD that's keeping the lining from building. And I'm a gynecologist. My aunt, who's my other aunt's, you know, favorite shopping buddy, is a doctor. And for whatever reason, my aunt ended up with a cancer of the uterus. And I know it is because of her history of this sort of irregular bleeding. She was overweight most of her life, which is also a risk factor for that growth of abnormal cells, because in our fat tissue, we also make estrogen. So sometimes if we're heavier, we may have more irregular bleeding. But I say all this to say that I don't know why she got cancer of the uterus. I don't know if she was having bleeding and didn't tell anybody, or she went to the doctor one time and he said, "Oh, you've always had that bleeding." Or if she talked to someone in church and the church friend said, "My doctor said it was normal," and then she just never went again. I cannot understand this, psychological reason why it got to the point where by the time they caught it, she had a hysterectomy, she had chemotherapy, but she died. And what we know about Black women especially is we get, and I'm seeing this in real time because when I trained um, at Georgetown, endometrial cancer or cancer of the uterus was one of those things that usually people would have funny bleeding, or they'd have bleeding post menopausal. You do a little biopsy, you'd catch it, they get hysterectomy, everybody was fine. Now what I'm seeing is even when women have their first episode of bleeding and you menopausally and you check it, sometimes these women are going on to have very advanced stages of cancer, even with that one little physical sign. And so I'm giving this roundabout story to say this is why I care so much about Black women, especially, but also women who bleed funny, because I think a lot of people don't realize that we're not supposed to have really pad bed soaking periods. We're supposed to have, literally like 3 or 4 tablespoons our entire 4 or 5 days of our period is all we're supposed to admit. And most of us are not having that. So fibroids are very common. Abnormal cells within the uterus can be common. And so anytime what I've seen before is that sometimes when I see a woman, especially if she's African American, a lot of times, and it's not always us, it's a lot of women, if they say I'm having heavy periods, you need to have a workup, a proper workup. You need to have an ultrasound. You may need to have a biopsy. We definitely need to check for anemia, because sometimes what you think is, oh, it's always like that, that's fine. I've had people think their periods are fine. And literally, when I get the results back, I have to send them for blood transfusions because they think that that's just normal. So the first thing we should do is you need to have a workup, a proper exam, an ultrasound, maybe a biopsy to find out, why are you bleeding heavy like that? Because sometimes if someone just gets a Mirena and they don't get any kind of diagnostics done, you may miss that there's a fibroid inside of the cavity, or that there's a fibroid near the cavity, or that there's something there that's causing you to have heavy bleeding. And so something like an IUD may not fix it. So a lot of times I find with diagnostics in the office, women that have fibroids near the cavity, near the lining, like inside the cavity, like literally here's the uterus, the inside, and this is the uterus around the fibroid, like an avocado pit in an avocado. And so you definitely have to make sure that there's nothing else causing the irregular bleeding, because certain things like taking a pill every month should make your periods lighter, or an IUD should make your periods lighter. And if it doesn't, your doctor needs to look for other causes of why you're having that kind of bleeding.
All right. The next question, any tips on how to locate a black OBGYN that is menopause savvy?
I mean, I think most of us have a good understanding um, of menopause management. Honestly, I mean, that's what I kind of think. I'm not really sure. I can't speak to, I mean, most of us black OBGYNs in the area know each other. We even have like dinner every like quarter. I organize that. And, there's a lot of us. Um, but not everybody feels the same about menopause management, because I've had some patients say that maybe not necessarily a black OBGYN, but some doctors like don't like hormones and they don't want to give me any hormones. And so people feel differently. I really think that if you make an appointment with your doctor and you're talking about your symptoms and they seem like they're listening, or they seem like they understand, and they seem like they're trying to offer you some suggestions, then that's great. They probably have a good understanding of it, and they probably have seen a lot of it, and they probably know how to individualize the treatment of it. But if you're with someone and they're kind of like negative about hormones, or they tell you just to ride it out, or it's going to be fine as soon as you finish flashing, and wait a few years, that's probably someone you need to transfer away from, and maybe find someone that might know a little bit more. And I can't tell you who that's going to be or how that's going to be, because honestly, all of our training is different. Everything that all of us don't know as much, because we don't see the same. Like, I love fibroids, bleeding, polycystic ovaries, irregular cycles, menopause management, but there may be other doctors who are better at bladder incontinence. And if I don't know something, I send someone to somebody that does. And I'm okay with doing that, because we all don't know everything about everything.
Yeah. And we have a hand raised. Sherelda Williams.
Yes, thank you so much. First, I'd like to say if you guys need a poster child for all of the symptoms, that's me. So when you were going through them, I'm like, this is my life. Like literally while we were here on the phone, I had a hot flash or whatever. Um, my first question is there a chance that it can go away and then it comes back? Because I felt like mine was getting better, but then it came back. And then my second question, one of the things that I did not notice as a symptom, but I wanted to know your thoughts on it, had to do with menopause and hair. So as far as hair thinning, hair loss, anything like that, because I'm just wondering, should I go more towards a dermatologist with what I'm having with my um, hair issues, or is this really related to menopause?
Can I ask how old you are?
Sure, I am 53.
Okay. You
And
just the
I
baby.
have a I had a hysterectomy.
Okay.
So
So you're young. Okay, so a couple of things. First, we know that studies have shown that Black women have hot flashes longer than everybody. Why do we always have to have everything the worst? Um, the second thing, so that's very interesting to know. So whereas some women kind of go through it, and then they get better, we kind of keep on going. And I have women that come in and they're in their late 50s and they've been in menopause for 5 years. And every woman that comes in over 50, I ask them, are you having menopause symptoms? And some of them say, every now and then, or I'm managing, or they may be on hormones, and so they don't notice it as much, and so it's good. But you can have them, wax and wane. It can be seasonal. It can be, I love wintertime and it's cold outside. But when it's hot, you know, it's gonna be easier for me to flash, because I tend to be very cold natured and cold all the time. And so when it's cold, I feel great. But then when my internal body temperature gets warm, I may have a hot flash. And so that's easier for me to do in the summertime when it's hot outside. And then there's some women who your ovaries may be producing estrogen in different amounts. You may initially be having these surges that are causing you to have hot flashes, and then your hormones may start leveling out for a while, but you wouldn't notice because you don't have a uterus, so you don't have a period. So you wouldn't notice what's going on. But then later on, you may notice that you're having hot flashes again, and that may be because you went from the erratic stage of estrogen to leveling off to now it's going back down, and so then the hot flashes return. So women with hysterectomies are some of the easiest to treat for menopause symptoms, because when you don't have a uterus, you don't have to worry about progesterone. So most of the time you can just take estrogen or wear a patch, and that, for most women without any risk factors, can produce excellent quality of life or reduction in your symptoms.
Thank you.
Right,
And then
the
what
next,
about the the hair thinning portion of that? Is that a part of menopause or not?
I think that's a part of menopause in the sense that estrogen, progesterone, testosterone, all of those in sync have a effect on your hair follicles. So anytime you change that, that can have an effect on your hair follicles. So that's one thing. The second thing is your decrease in your estrogen also has an effect on your protein synthesis. So one thing we also recommend, in addition to strength training for building muscle and helping with weight loss, is increasing the protein in your diet, less sugar, less carbohydrates, and that can really help you, with your hair growth. My mom, for instance, my hair has always been really thick, and I'm not sure if it's thinning out or not, because we got different treatments now. Somebody can do a blowout with a brush that I could never do when I was 20. My line name was Leo the Lion because I didn't have a relaxer, and my hair was like, we walked online back then, so it was crazy. But anyway, that's a whole other story. Um, my mom said her hair was thinning out. And so the one thing I recommended for her is I told her she needs to put more protein in her diet, and that can be very helpful. And that also, is good for us as we get older as well.
Well, thank you so much. That's one thing that I did not think about, so I will try that. I appreciate everything you've said. It's so helpful. Thank you.
You're welcome.
I have a few more questions here.
Okay.
I know you mentioned disconnecting from electronics to work on better sleep habits. She's trying, it's not working. What can she get over the counter to help her sleep? The melatonin is not work. Well, is working.
Okay. Melatonin is working.
Yes.
Oh, melatonin is fine. Some women can have some side effects from that. Sometimes if I need to get deep sleep, or if I'm really, really tired and I just need my body just to really rest, I will take like half a dose of Benadryl, because I'm very sensitive to medicines and I don't want to be groggy the next day. Warm baths, chamomile, sometimes just stretching exercises, but certain things like uh the half a tablet of Benadryl, magnesium. You can take a tablet of magnesium at night. I take that as well. I took it for joint pain, actually, not joint pain, muscle cramps, and I realized it does help me sleep, and it is supposed to help you sleep. So, that is one thing you can also try. But you also want to make sure that there's nothing else physiologically going on, that your thyroid is in check, and you're not having anxiety or things that are kind of worrying you, because that can also affect your sleep.
Okay. Think we have a hand raised. Sakia?
Yes. So, what is the difference when, as far as affecting your hormones, if you have a hysterectomy and or your ovaries removed? How does, like, one or the other, if I'm asking that correctly?
Excuse me. So your uterus produces no hormones at all.
Okay.
So once that's removed, the only thing you notice is you're not going to have periods. When we treat you for menopause, it's helpful because the two hormones that you need to have when you have hormone replacement, when you do have a uterus, is you have to have progesterone, which helps protect the lining of the uterus from becoming fluffy, overgrowing, and having spotting or bleeding. And then you need estrogen. So the two work together. So when you don't have a uterus, you can just use estrogen because you're not worried about bleeding or cancer of the uterus. If you've taken out the ovaries, you're having what we call surgical menopause, which is all of a sudden, boom, your estrogen is dropping down to zero. Testosterone is also made in the ovaries. And progesterone, of course, is made in the ovaries as well. So if you don't have the ovaries, your estrogen and your progesterone are going to go almost to zero, because that's, like I said, some is made in your body fat. And your testosterone is probably going to go very, very low as well. So your question is, then how do you treat that? Or
You answered the question as far as how it affects your hormones.
yes.
Okay, yes, you did. You answered it.
So
All right.
removing your ovaries is more dramatic, because instead of gently going into menopause, it's sort of all of a sudden, because you've removed the ovaries, which is the source of most of the hormones that we make.
Thank you.
All right. I see someone said that they have a cool pillow and it works for them a lot and they love it. Someone also says they had an IUD and still bleed lightly. So after this conversation, they're going to make a follow-up visit. And there's a question about ways to shrink fibroids depending on the size.
Yep. So many different ways. I'm certified to do a procedure called Sonata, which is a transcervical radio frequency ablation of fibroids. So depending on the size of fibroids, it's an outpatient procedure where we go through the cervix and put in an ultrasound probe that puts um, uh, metal probes through the fibroid, and it heats the fibroid up and destroys the blood supply, and it's supposed to reduce your bleeding by about 50% for people who have heavy bleeding and who do not want surgery or the removal of their uterus.
And someone else actually put in here that they recently had an ultrasound for fibroids, but the doctor suggested a hysterectomy at one point, but they ended up giving her an IUD to help. So far, so good.
Mm-hmm.
And another question, do you see teenage girls that just started her period? Her daughter has a rough time during her cycle. She literally throws up and is weak for about 2 days each month. Her primary doctor doesn't know what to do.
Tell her to come on over. And I have a wonderful a team. I have Dr. Warren that works with me, and I have also we call her Dr. Brenda. She's a nurse practitioner, but she has a doctorate. So we DNP to give her props because she has a doctorate, but she's not a medical doctor per se. But she has an extensive amount of training with young people. But she worked with Planned Parenthood for over 10 years, and she takes a lot of time. They do a lot. She does a lot of education with the young women, and so I usually try to direct them towards her because she has a lot more time to kind of talk about things, and we all work together. A lot of times, if someone comes in and they have a problem, they may see our nurse practitioner first, but then they'll follow up with me for the ultrasound, and then Dr. Warren and I are the two physicians that do surgery. So we all try to work together as a team from that standpoint.
And we did put Dr. Freeman Kwaku's information in here once again, so please write it down. Here, another comment, those hot flashes and cold flashes send me to Jamaica and Alaska all in one day.
Mm-hmm.
All right. And I think that, yeah, we answered that question. Someone said very informative, thank you. And they appreciate the call. And another question, what should women in their early 40s do to prepare? You mentioned weight-bearing exercise, increased protein, a decrease in sugar and caffeine. Are there any other behavior changes you would recommend?
I think that's a pretty cohesive list. I mean, everybody's different. What they need is different. Um, But I mean, I'm really at the stage of life. I'm 50, I'll be 57 in September. And I'm just at the stage where, managing my weight is very important. Eating better is very important to me. I try to go to the gym and exercise, several times a week because it makes me feel better. And, I think that that's really, really important. I think that that solves a lot of problems that we have as we get older, is if we eat a little bit better, try to get some exercise, um, you know, work out any lifestyle issues, do a lot of self-care, things that just increase or enhance our quality of life, which is, to me, is really, really important as we get older.
All right. Is there a recommended dosage of magnesium?
The over-the-counter supplements, I think they're 200. I have to look at the bottle, but there's different forms of it. I think it's magnesium glycinate that they recommend, and I think it's 200 milligrams. But usually, if you go in the vitamin section, there's different magnesiums, and depend on the type of magnesium and how it's digested, it may have a different dose on it. So usually, I just say whatever type you pick up, just follow the manufacturer's instructions on it, which is usually probably 1 tablet or 2 tablets a day.
Has there been any research on how PCOS or low iron can affect menopause?
I would just say, kind of circling back to one of the things we talked about very briefly, is that PCOS is an irregularity in the hormones that can a lot of times cause women to have maybe increased hair growth in different places where they don't want it. Usually it's a deposition of fatty tissue on their tummies, irregular menstrual cycles, and sometimes difficulty getting pregnant. And PCOS is one of those gynecologic conditions that I really like to try to do a lot of education about with women or younger, because a lot of times they say, oh, my mom, everybody in my family have periods once every year. But I let them know that that may be what is normal and how your body works, but we shouldn't let it just do that, because that can cause over time the growth of abnormal cells or precancerous conditions, or even cancer of the uterus later in life. So I really try to let women understand, or help them understand, that that may be how your periods are, or maybe how they've always been, but we definitely need to make them either regular, or make sure that your body is cleansing itself, or you're not having a buildup of the lining. So PCOS and menopause, I would say that would be the connection that I would be most concerned about, that women will go from, I don't have regular cycles because I just don't, to now I'm having irregular cycles because something bad is happening and nobody knows, because I'm not complaining because that's always the way I've been. And then anemia is usually a secondary response to the fact that your cycles don't come when they're supposed to. And when they do come, sometimes they last a long, long time, or you have really, really heavy bleeding, and that can lead to anemia because of blood loss. So the anemia itself doesn't cause problems in menopause, but it's more the condition that causes the anemia that can cause other problems when you do get near menopause or in menopause.
Okay. Another question, how often do you see anxiety and depression associated with menopause, and how is it treated?
To varying degrees. I've had patients who maybe have been on something in the past, and then they're getting towards menopause and they're having hot flashes and they're complaining of more anxiety. And then I'll ask them, have you ever had anxiety? No, yeah, I used to take this medication, but then I stopped. And then I'll say, you want to start it again? And they'll say, maybe I'll give it a try. And then I bring them back and they say, I feel so much better. I've had everything from, worst case scenario where one person could barely function. And I had never seen anyone who had that much difficulty. And I put her on hormones. And when I saw her a month later, she was a completely different person. And that's, so I see it very often. Sometimes what I find when you kind of tease out different things that are happening with us as women is that we're going through other things at the same time. And so it's kind of hard to say, this is all just menopause. Sometimes it's I'm 52 and now my children are leaving and I'm having marital problems and I'm anxious or I'm depressed because of that. And now I'm blaming it on hormones. And it's really like a combination of everything's happening, but the hormones are not making the situation better. So I usually look at that as my goal is to not always look at things medically necessarily, but to look at things holistically and see like, you know, Laura Portia will tell you, I'll sit there and talk to patients about all kinds of stuff. And usually I like to know like what else is going on. You know, sometimes patients, for instance, will say, I don't have a lot of sex drive. And then I'll say, do you like your husband? And they'll say, no, not really. Well, I didn't like him. I wouldn't want to have sex with him either. So sometimes it's like things that people think are like related to hormones, but it's like a sociologic kind of factor that is all kind of jumbled up. And once we kind of tease out, well, it sounds like it might be a little bit of this. So let's put you on something and see how you feel. And then when they come back, they say, well, I'm sleeping better, but now I still have these other problems. You know, maybe I can direct you to someone to talk to or your therapist, which I think is very helpful um, in different stages of life. So that's just something to think about. What's the laugh? That's
And
very common though. Very, I mean, like, let's get straight
that's
to Mark. Do you even like him? Well, no, not really. Well, if you don't like him, I wouldn't want to have sex either. So, and then they kind of laugh, and then they realize like this visit is ridiculous. Like, why did I even schedule this? Because yeah,
There is another magnesium question. Someone did ask, is there anyone who should not take it?
magnesium or hormones.
Just magnesium.
I would probably discuss that with the primary care doctor, like if they have some medical condition that I'm not aware of as a gynecologist. But I mean, magnesium is just a vitamin. It's like taking calcium. People who shouldn't take calcium are people who have elevated calcium because of the gland in their neck, the parathyroid glands. But I'm not aware of any medical condition where you should not take magnesium.
And there's another question here. How do you feel about the hormone pellets containing estrogen and testosterone?
And I think I talked about that.
Yes.
The reason why I'm not a fan is because you cannot control the absorption rate of those hormones, that they often end up having some kinds of side effects because of the absorption not being controlled, that the people who put the pellets in are often not able to manage the side effects of the pellets. They say, oh, go see your gynecologist. And so then they come to me and it's kind of a mess. And then I'm supposed to fix it. And the first thing I would say is I'm not a fan of why you even did that in the first place. Because it's, because of the reasons that we talked about before. But then, also that there are FDA approved ways of getting that same hormone that are covered by your insurance. And most times when people are getting those pellets, it's not something that they can get a prescription for, go to the pharmacy and they pay $15. They're paying hundreds and thousands of dollars for blood work and pellets. And there's a money making component to it too that I just am, a lot of us are just kind of don't really understand. Why would you do that when you can just wear a patch?
I have another question. Do you recommend still seeing your uh, gynecologist if you have had a total hysterectomy?
Yes. I feel like every woman, most private insurances will cover you seeing your gynecologist and your primary care doctor. And we really do specialize in different things. Like, I'm not going to talk to you about diabetes and high blood pressure, but I am going to ask you about your libido and if you have vaginal dryness or if you're having any kind of discharge, odor, different things that women may not want to discuss with their primary care doctor, or they may be embarrassed to even bring that up. And so that's why we specialize in what we specialize in, because there's certain things that I want to make sure are, women are not having difficulty with as they age, that your primary care doctor just doesn't have time to ask all those questions.
All right. I think that's all the questions. We have 9 minutes left. I don't see any other questions in the chat. Again, we want to thank Dr. Freeman Kawaku for joining us this evening and providing us with very valuable information, because it's going to be a struggle for many more years to come for some of us. I don't know when it's going to stop, but because right now, as people were saying, I'm having a cold flash, but I was having a hot one right before I started this call. So uh, so thank you again. I would like to close out with, I don't know if SOAR president would like to close out with some comments, and then I'll have our May week co-chair, or excuse me, my May week chair come on if she would like to say something, and then I will provide some announcements.
Yes, I am accepting new patients. And thank you for having me. I really appreciate this opportunity to be able to discuss this with you. And the last thing I'll say is that, ladies, I'm right there with you. I got 4 kids. One has finished college. One is coming out of Aggie Pride this Saturday. I'm so excited. One is going to college next year. And I got a 13-year-old because I had her at 43.
Oh,
I got
wow.
thinking. I was thinking wanted a girl at 43, but she's all that in a bag of chips. But we need to live our best lives. We need to be living our best lives. We need to be eating well. We need to be trying to do everything we can to live healthy and happy. And if you're bothered by heavy periods, hot flashes, anything, especially gynecologically that we can help you with, please come and see me if you don't have your own doctor, because um, life is too short to be not living your best life. And for most women, these things are safe, and there's no need to suffer. There's no need to have vaginal dryness, and there's no need to have painful sex and, just feel miserable. We just want to feel as good as we can. So I just encourage you to try to do that.
All right. So, Bridget Herring Williams, you there? All right. Well, then I will go on to Miss Portia McDuffie for some closing remarks.
We are deeply grateful to Dr. Freeman for providing us this invaluable insight into perimenopause and menopause. For many of us as Black women, this knowledge has been missing, and we now have a much better grasp of what to expect, recognizing its unique presentation in each of us. Thanks to this session, we can now confidently share this understanding with others experiencing these changes. Finally, thank you to our wonderful audience for your active participation. Have a lovely evening.
Thank you, Portia McDuffie. Again, she is the co-chair, or excuse me, the chair. Keep saying the chair of the May Week Committee this week, and that goes into our announcements. We have so many things this week. Come join us this Thursday, May 8th at 6:30 p.m. at Dorton Park for our Mind, Body, and Soul Walk. And then come join us again on Saturday. Everyone is invited, all ages, to our first ever community carnival, and that will be from 10 a.m. to 2 p.m. at the Bethel Enrichment Center at 1209 Opal Street in Kannapolis. Again, we thank everyone for joining, and have a great week. Good night.
Good night.